All, this is Dr. Mubin Sayed from Drbeen.com. Welcome to one more show. Today we will talk about two important things. Number one, some studies that we look at for hydroxychloroquine. The wars about hydroxychloroquine continue. There are studies that show this is useful. There are studies that show it doesn't work. I wanted to make sure that we look at the latest landscape and kind of look at both the studies that say it works and the studies that say it doesn't work. And again, my point is not to knock down the hydroxychloroquine or prop it up. My point is for us to look at both sides and then make up our own opinions as well. So that is one. Secondly, I also wanted to clarify a number which I think is really going to excite you about the vitamin D study that we did yesterday, which our dear Cool Bean Jim Mattox had sent to us. I wanted to show you a number that you would really feel excited and happy about. So these are the two primary discussion points that we'll do today. So let us start. So this is Drbeen.com. All of these lectures are actually ending up here. Now, before we start with the hydroxychloroquine and some clarification on numbers with vitamin D, check this out. This is WHO's site, and I have the link in the description. WHO says, I know that some of you are going to say, why are you referring to WHO? And some are going to say, why aren't you referring? So here, vitamin D and mineral supplements cannot cure COVID-19. Micronutrients such as vitamin D and C and zinc, so they are actually honing in on those that people have been talking about, are critical for a well-functioning immune system and play a vital role in promoting health and nutritional well-being. There is currently no guidance on the use of micronutrient supplements as a treatment for COVID-19. Then look at this line. I laughed. WHO is coordinating efforts to develop and evaluate medicines to treat COVID-19. That is kind of an underhanded way of saying, we don't really care for these vitamins. We are working on getting you some medicines, and they are working on it from ever. Then here, this I wanted us to actually look at it while we're discussing about the hydroxychloroquine. We all know WHO's stance there, so I wanted to show it as well, that hydroxychloroquine or chloroquine, a treatment for malaria, lupus, and RA, has been under study for possible treatment for COVID-19. Current data shows that this drug does not reduce deaths among hospitalized COVID-19 patients, nor help people with moderate disease. So you can read the rest on their site. So now I'm going to show you studies that are actually kind of contrary to what WHO says. So this is one of the studies. This is out of Belgium, where they're saying that low-dose hydroxychloroquine therapy and mortality in hospitalized patients with COVID-19 in nationwide observational study of 8,075 patients. So the key thing here is hospitalized patients. And I'm going to hone in on this one word and what does this mean in terms of understanding the statistics and the percentages. Then there is another study. This is actually, they all are meta-analysis. So this is also a meta-analysis of 5 studies. And look at this. This is by one of the contributors, or I think the lead researcher here is Harvey. So I think that we all know, I think he is from MIT, correct? From Yale. And he has been very vocal about hydroxychloroquine, and he's been very vocal about testing and all that. And some people have been really upset with him. Some people admire him. I reached out to him a couple of times to say if he can come in our show, and he refused, saying I'm very busy. So Harvey is part of this meta-analysis, which is actually an interesting thing. And then there is this study in Lancet, and that is about the patients of rheumatology, so rheumatological diseases, those patients who are already receiving hydroxychloroquine for rheumatological diseases, and if hydroxychloroquine is keeping them safe. And they said it is not keeping them safe. And so I want to see them all together. So let's look at it. And this is a data point that I want to use today. I realize that the mortality and hospitalization The percentages are different for different geographies, different demographies, different ages, sexes, and so on. However, for the clarity of the formula, the calculations, I'm going to use this number. So once you see the formula, you can actually use whatever number is right, which you think is right, and then do the math. So let's start the discussion itself. So the first study that I showed, this is the low dose hydroxy. This is the Belgium study. Low dose hydroxychloroquine. And what do they mean by low dose? What they did was, if you see here, they were giving 400 milligram hydroxychloroquine on the first day twice, morning and evening. So that is a total of 800 milligram on the first day. Then 200 milligram twice daily. That means 400 milligram daily after that, and a total of 5 days course, and a total of 2400 milligram of hydroxychloroquine in 5 days, which they call low dose. I think it is fine, but they call it low dose. The other thing that is really important to note in this study is that this is on the hospitalized patients. So this is not on general public. This is not a prophylaxis. This is those patients that have ended up in the hospital, that are COVID positive and had enough of severe symptoms that they needed to be in the hospital. So it is on the hospitalized patients. And what did they find? What they found was that, so the number of patients, 4,542 patients who were taking hydroxychloroquine or who were given hydroxychloroquine, versus 3,533 patients who were not given hydroxychloroquine. And they both standard therapy continued as well. And here is the difference in mortality. The difference is that those patients that were given, so hospitalized patients that were given hydroxychloroquine, their mortality rate was 17.7%. And those who were again hospitalized but were not receiving hydroxychloroquine, their mortality rate was 27.1%. So there is a difference. The interesting thing in this study is, number one, there is no zinc there. Secondly, in this study, when they added azithromycin, the mortality rate actually was 1% higher. So it was 18%. All of them were hospitalized on which this study was done. 60% of the participants were greater than 65 years of age. So that is the structure of this study. What does this tell us? What is the takeaway? So throughout this discussion, I'm going to show you some studies that say it works and some studies that say it doesn't work. I'll give you my opinion first. My own management, my own treatment has shown me that ivermectin and hydroxychloroquine and vitamin D levels, they work for sure. Here we have a study that says it works as well. And now I want to put this in perspective, and I want to put the data for vitamin D yesterday that we did. And by the way, I received so much of appreciation for yesterday's vitamin D discussion, and I owe it to Jim Mattox as well for referring it. So thank you very much, and I'm really glad that there is an outcome. I think the next topic that I'm going to discuss, you will become even more happy about vitamin D, and I think you'll become even more convinced to continue to have your vitamin D levels higher. One more thing that I would like to answer. I thought I'll answer that tomorrow, but I'm just going to answer this today. There were a lot of comments in YouTube and Facebook that what should be my daily dose of vitamin D that would guarantee that my levels would be 40 nanogram per milliliter. And the answer is that it really depends where you're starting from. Somebody whose vitamin D level is, let's say, 10 nanogram per milliliter, their daily dose need to be different compared to somebody who's at 20 or who's already at 30 or who's already at 40. Number one. Number two, your body habitus is going to also decide how much vitamin D daily should be needed. obese folks need a different level and versus others. And we have done a discussion before that what is the percentage of difference. I think it is 1.5 times. So if a non-obese person needs 5,000 international units on daily basis, an obese person would need 1.5 times of that. That is 7,500 international units on daily basis. So body habitus is important. Then your activity levels. What are you doing with that vitamin D that you have taken? Are you doing exercises, rigorous things in which vitamin D is going to be consumed fast? Then your kidney status, your GIT status, your absorption status, your irritable bowel syndrome, for example, or small iliac disease, or so on, small intestine diseases. So it is difficult to say. Your absorption levels are very important. So it is difficult to say that this is the number that you should take. I have seen some doctors, what they do is that right in the beginning, if they do not know the levels, they give 200,000 international units right in the beginning, sort of a stat dose, and kind of up the numbers, and then they give a maintenance number. I would rather have you test your vitamin D levels before you start. And then the other thing that I saw a lot yesterday in comments was that people who had vitamin D levels at, let's say, 20 nanogram, they had been taking 5,000 international units daily, and within a couple of months, they reached to 30 and above. But again, what is their exact situation? How much are they using their vitamin D? What is their infection rates? What is the absorption rate? Are they taking magnesium with that or not? And so on. So there are so many factors that a per kilogram body weight international unit is not easy to calculate. It has to be case by case. So with this, let's look at this concept of something that is in hospitalized patients. For example, today we're talking about hydroxychloroquine in hospitalized patients. So let's take yesterday's example. Yesterday they said in the study that vitamin D levels of greater than 40 nanogram, greater or equal to 40 nanogram per milliliter in hospitalized patients of the age more than 40 years was associated with mortality rate of 6 point something. What does that really mean? You know what that means is this. First, we calculate that out of all the cases, what is the percentage of people who end up in hospitals? And there, again, different ages, different sexes, different geographies have different numbers. But I'm just going to use some standard numbers to calculate the formula, and then you can plug in the values for what are the right numbers that you know for your area, for your age, for your sex. So here, let's say we look at this data here. This is US data, and this is about the hospitalization and hospitalization percentage out of all the cases. And again, you can imagine that the percentage is going to change based on how much testing is being done and how much we know are the cases. But let's use this data for a second for our purposes of our discussion. So here, the folks who are greater than 50 years of age, I know that it is showing very small. I have the link in the description as well. You can see it over there too. I try to make it big and it doesn't really work very well. But what I'm seeing here is for the patients whose age is greater than 50, the hospitalization is 28.3%. That means out of 100 patients of COVID-19, confirmed cases of COVID-19, if their age is greater than 50, then 28 point something 3% are ending up in hospital. So now let's use that data for a second. And we go back here. And we say, all right, assuming 28% is the hospitalization. That means this 6%, remember we talked about it, that 6% had the mortality if the vitamin D level was greater than 40. Again, this is the data I showed you is from the US. The study is from the Iran. So these are not pluggable numbers, but I just want to do the math with you. So here, this means 6% of 28% equals 1.68% mortality rate. Just the vitamin D levels greater than 40. If we assume this data, if we can plug America's number and Iran's number and put them together, it is 1.68%. That is a significant reduction in the mortality. Let's use global number. Globally, we say that 20%, 19% of the patients out of all 100 people who become COVID-19 confirmed, 19% will become hospitalized. So for my own math purposes, I'm going to say 20%. So 6% of the 20% is 1.2%. Just having the right vitamin D levels can give us this much of a potential that folks who are at higher risk because of age and comorbidities, their mortality rate drops down in 1%. That is a kind of mortality rate that is seen in 20 to 40 years of age people. So it is not just the 6% that we studied yesterday. It is the 6% of 20% or 6% of 28%. So it is a smaller number. It's a hugely important thing. And look at this. In the same study with vitamin D yesterday, we also saw that greater than 40 years of age, overall mortality, that means mixed people with the vitamin D level greater than 30 and lesser than 30, whatever were their levels, they had 20% mortality. Which means if we do the same thing, 20% of 28% is 5.6%. So overall 5.6% death rate. But if vitamin D is being taken in the 40 nanogram and above, then 1.68% death rate. That is really important. And I'll show you that even hydroxychloroquine prophylaxis does not help that much. So if today's lecture, if one thing can be taken away, that is that vitamin D levels greater than 40 nanogram per milliliter are actually even more effective than hydroxychloroquine and ivermectin, which is excellent. Now let me show you today in the study, the one that we just saw. In that study, they again hospitalized patients. Studies from Belgium, I'm again going to use US numbers. So don't get mad at me that why did I use the US number? You can get the Belgium number and use them. I just want to show the data here. So 17.7% was the mortality. And let's say we use global data of 20% hospitalization. So that means 17.7% of 20%, which is 3.54% mortality. With hydroxychloroquine, mortality rate it drops from 5.42% to 3.5%. But consider this, if somebody was taking vitamin D, then it drops down to 1.68%. Isn't that interesting? So now if we combine them, vitamin D and hydroxychloroquine or vitamin D and ivermectin as prophylaxis, I feel that I can make this statement. And this is not something that is verified. There is no study. I feel I can make the statement that we may be able to prevent deaths 100%. So it's a bold statement, I know. So you can beat me up for that as well. That is fine. But having vitamin D and hydroxychloroquine and ivermectin or another combination with these things, I think can reduce the mortality rate in the high-risk patients down to almost negligible. This is what I was excited about today. So now I'm going to go back after this math. So wherever the word hospitalized is seen, please see that it is not about all the cases, that percentage. It is the percentage of a percentage. All right, so next study. Next study is about the, if you see here, this is the Harvey study. So what they have done is it's a meta-analysis of 5 other studies which were done in US, Canada, and Spain, I believe. And then they have done data curation and data processing and came back and said what they saw. So here we are. So what they did was, this is a meta-analysis. The question in their mind was, will hydroxychloroquine reduce the incidence of new infections? So here what we need to be careful is, they're not talking about hospitalized patients. They are talking about general public before hospitalization. So this is something that is, you can say, pre-exposure prophylaxis, post-exposure prophylaxis, and outpatient management with hydroxychloroquine, like I do, or Dr. Zelenko do, and others do. Excuse me. So now what are they saying? What is the type of patients? Pre-exposure prophylaxis, post-exposure prophylaxis, and outpatient management. What is the analysis they did? They looked at 5 studies out of Canada, US, and Spain. The total patients they saw in those studies were 5,577. And they made a very interesting point, and that is there have been about 1,840 studies for COVID-19. Out of them, majority, 62%, have been on the patients in the hospitals. So one point they are making is, and I think I say that all the time as well, I'm happy that Harvey Reich said the same thing, and that is, we do not have decent studies for outpatient patients. There is no wing of WHO or CDCs or FDA or something that is working together to curate the data and process it and bring it back to us. There's nothing like that. So 62% studies are all in the hospitalized patients. Even the study above that we saw is in the hospitalized patients, where in general hydroxychloroquine should actually be less useful. But even then it is useful over there. So they looked at these patients, and what they found was that hydroxychloroquine's use reduces the chances of new infection or hospitalization or death by 24%. And the P is 0.025. One comment they make, and I'm going to go to that study now. One comment they make is that all of the studies that they saw, the 5 that they chose, they did not complete the studies. Number one, they were terminated early. Secondly, the studies were done mostly on youngsters, so the population data and the risk factors were skewed. Because of that, the powers of the study are not very good. So instead of giving a statistically significant answer to us, what they said was that these studies, even when they were terminated early, and even when they had a slice of population that was not representative of the whole population, even then, when the hydroxychloroquine was used, the results were that it improved the chances of survival. It improved the chances of not getting the infection. So there is a positive outcome. Right? So if you see here, I'm just going to very quickly go over some of the pieces of this one. So design of this study, this is Harvey Reich study, systemic review and meta-analysis of randomized clinical trials. So that's one. Secondly, results 5 randomized controlled clinical trials enrolling 5,577 patients were included. Hydroxychloroquine was associated with a 24% reduction in COVID-19 infection, hospitalization, or death. P equals 0.025. Not bad. And then they've done a good, I mean, Harvey Reich is an epidemiologist, so you're going to expect some good data from him and thinking from him. So there is a lot of good thinking over here. And one thing that I was going to show you is this: various randomized trials of hydroxychloroquine for pre-exposure prophylaxis, post-exposure prophylaxis, and outpatient treatment have been performed. Individually, these clinical trials have yielded estimates of effectiveness that have not reached statistical significance. And the reason why have they not reached? Number one, these studies were terminated early. Number two, the demography, the slice of patients that they used were low risk group. So they were not a representative of the population. So even with those considerations, even with those limitations, what they finally concluded was, so I'm going to go to their conclusion. I had been reading and making sense of this the whole day today. 1 second. So conclusion, the randomized clinical trials performed to date demonstrate that hydroxychloroquine use in outpatient safely reduces the incidence of composite of COVID-19 infection, hospitalization, and death. So the takeaway, if we can't get hydroxychloroquine, then vitamin D is a must to 40 nanogram per milliliter and higher levels. If we can get hydroxy as well, and if our body allows us, we don't have any cardiac issues, or we do not have any eyesight or retinal issues or blood disorders, then it is an important thing to take. If not, then ivermectin is another choice as well. With these combinations, I would repeat, I think we can control the pandemic. So this is the other one. And then finally, the flip side of the coin. Another study that says no, hydroxychloroquine does not work at all. So this is that study here. This is the study date is September 21. So it's a recent study. Once again, it is not a prospective double blind placebo control type study. This is also an observational study. And what have they done in this one? What they did was the following. They wanted to answer the question that those patients that have been receiving hydroxychloroquine for rheumatological needs, are they safer compared to others? And so they used data from Veterans Health Administration clinics. All patients were greater than 18 years of age. It was a retrospective cohort study. There were 10,703 patients who were receiving hydroxychloroquine for autoimmune diseases. 21,406 patients who did not receive hydroxychloroquine. Incidence of the COVID-19 disease, meaning the catching of the disease, let's say in simple terms, no difference. In those who were receiving hydroxychloroquine, 0.3%. Those who were not receiving hydroxychloroquine, 0.4%. Then mortality, no difference. There was slightly lesser mortality in hydroxychloroquine, but they say it was not significant. So this is the flip side, and they, at least from a data point of view, they have done a rigorous collection of data, categorization of types of diseases, then why were they getting hydroxychloroquine, how much they were getting, and so on. So they have done good analysis. Here is the PDF. However, the result is hydroxychloroquine doesn't work. So this is the discussion for today. I know I wanted to talk about prophylaxis, but these were important things as well for us to kind of understand. Tomorrow we'll do our open forum. Day after tomorrow, there is a doctor in Florida who has been using bromhexine and has a protocol for bromhexine, and they were very excited and they wanted us to chat. So tomorrow I'm going to chat with them, and if they have something decent that we can share with the cool beans, then on Saturday I'm going to invite them to have a talk here with you all. So that is the discussion. Thank you very much for your time. Please do me a favor, share and subscribe and like this one as well. Especially this one has a further convincing point for vitamin D. So whoever you shared vitamin D video with, please share this as well and ask them to watch first 10-15 minutes where I talked about that. And that is the talk today. Hopefully you'll stay safe, stay blessed, stay protected. I'll see you tomorrow and we'll go from there. Thank you.